The other area where I think these agents might have some headway would be in adjuvant therapy and in people that, where you've treated all the disease you know of, but you're using them for long periods of time, and you can imagine a drug like the Non-T790M, for example, might be a very good drug to use in that setting. The other thing I wanted to bring up is, at least half the resistance is not due to T790M. And they're really, while these agents do have a little bit of activity in that setting, it's always hard to determine how much is true activity versus just retreating a patient who had been off of the EGFR inhibitor for a period of time. But I've been impressed, from some of the work that came out of Memorial, and we were involved at Yale and Vanderbilt with William Powell and his group of the cetuximab plus afatinib, that combination. And that's a combination where we know there is activity both in preclinical studies and in the clinic against non-T790M resistance. And actually, SWOG 1403 just started enrolling patients. And this is a trial that's actually looking at that combination, cetuximab afatinib versus afatinib, for the first-line treatment. So it's another question of EGFR mutant disease. Another question, will that give us a longer PFS and survival?
Yeah, and I think it brings up a point that, I think the standard of care in this population is repeat biopsies and repeat testing over time to determine what the mechanism of resistance is.
Right, let the science drive the therapy.
Right.
And the nice thing is, talking now, every one of our centers and probably most of the people who are watching have the ability to get a biopsy, whether it be tissue or now the liquid biopsy, which wasn't the case, a while back.
I have a question for the group. I saw a patient just yesterday, and she was biopsied and was waiting for the results of her tests. And her question was very astutely: is if I'm negative, is it reasonable for you to biopsy another lesion and see if I'm positive? And she turned out to be positive, so it didn't matter.
Is this positive for T790M?
T790M. So I think that's another question that I would have for the group.
Well, I was going to ask Jeff. One of the things that I was relatively impressed with was the activity of rociletinib in the T790M negative. I think the response rate was 37% or something like that. And I've heard a couple of people say, well, if it works to a lesser degree if you're negative and it works better if you're positive, why not? Why do you test? Why not just give everyone a trial of it like
all of these
I
trials,
don't think they were as durable, though. Those responses were not that durable.
And all these trials have enriched for T790M patients, patients who were T790M positive with the local assay, but not with the central assay. So it's a murky question of how do you call positive. I've certainly seen those patients who just get the drug and zip right through it and progress, right? Those patients are real, and you're not helping them out by giving them the wrong drug. I think we can sort out this biomarker. In the patient who's biopsy negative, I do sometimes see plasma positive. And then I see that the biopsy, if it's retested with a more sensitive assay, becomes positive. So there does have to be some persistence to find it. So it's a little bit of a moving target. But there are some patients who don't benefit, and we want to find those people too.
Right, and there was the Mass General group across town from you presented some data. I think it's recently published looking at serial biopsies over time. And there's differential expression, whether that's clonal heterogeneity or what that's about. It happens.
And does the status change because your biopsy just misses stuff?
Right,
or
exactly.
the biology actually changes?
Right. So interesting.